I have the great pleasure of introducing to you Dr. Craig Gedye. Craig is a medical oncologist and cancer researcher who trained in New Zealand and Australia, and for some reason he thought Toronto would be a great place to come to in 2009. I'm not sure how he's enjoyed the winter, but he's still here. He's undertaken a postdoctoral fellowship at the Ontario Cancer Institute studying cancer stem cell biology. Craig also holds a clinical fellowship at the Princess Margaret Cancer Centre in melanoma. And Dr. Gedye is the second recipient of a Kidney Cancer Canada Canadian Institute of Health Research Fellowship that we participate in. And for those of you who've had a chance to look at our newsletter, and if you haven't, we have copies outside. Craig also has an article in the newsletter talking about the research that he has undertaken through our support. So, Dr. Gedye, the podium is yours.
It's a great pleasure to be here, and again, thank you for the support that you've been able to give me to continue my research here in Toronto. It was a good idea to come here. We knew that this was an area of a great place to live and a great place to do scientific research, and we've really tried to embrace the winter with skiing, and we've embraced the summer and with sailing and all sorts of other things here. So we've had a lovely time. Thank you for alluding to my research. There is a little blurb in the newsletter, but I'm not going to speak about any of that tonight. I was really just asked to sort of give the broadest possible overview of kidney cancer from a clinical perspective. So it really is 101. So hopefully it's still very helpful. It's not pitched too high or pitched too low. So, and we'll address some questions later. So if I can. Yep, good. So I'm going to just very briefly talk about what cancer is, and in particular what kidney cancer is, maybe just touch on some of the causes, and then what might be the symptoms and signs of someone who develops a kidney cancer, and then how we actually diagnose it and test for it. I'll speak to the very briefest possible thing about types of kidney cancer, because Dr. Shrigley is going to talk about that in depth in terms of understanding your pathology. And then I'm just going to very briefly touch over all of the kinds of treatment for kidney cancer. And kidney cancer is very interesting, is that there are lots and lots of different kinds of treatments that we can use for it, depending on where the cancer is and what the cancer is doing. And I'll just very, very briefly speak about complementary and alternative therapies as well. So what is cancer? So cancer is a word that causes all sorts of conniptions and emotions, and then the next problem is that doctors then turn around and use lots of euphemisms and other words. So you might hear a word called neoplasia or neoplasm, which is the sort of the Latin word for it, but it means new growth, which is really what describes it. But doctors or other people will talk about a tumour or a mass or a lump or a swelling or a lesion or a bump or something. But really what a cancer comes down to, it's an area of part of your body that's growing abnormally, out of control and out of context compared to where it started and from sometimes where it moves to. So it's not responding to those stimuli appropriately and growing without control. And so what causes cancer at the most basic level is changes in the DNA, the changes in the genes. So all of us carry a message of DNA that builds every cell in our body from when we're just an egg, and then we turn into a baby and into a person. We have that DNA, and a cancer is when those genes, that DNA gets out of whack, out of sync. They become changes. So when you look at the top part here, if you look at the normal DNA, it's very ordered, and then perhaps I've represented it here as like changes in music. You have a very complicated and chaotic piece of music where there's complicated and chaotic changes in the genes. And so that's one way of looking at it and thinking about it like the music score of music. And then when we look at it actually under the microscope, at the top there you can see the normal chromosomes, the normal DNA, and you can see there's lots of little pairs of pieces of DNA, and each of those is a pair of chromosomes. And then in the bottom is a very extreme example of somebody's cancer, or in fact probably a cancer that's growing in the laboratory. But you can see that there's lots of, there's there's 4 there, there's a mixed up group here, there's lots of disorder. So depending on the different people's cancer, they have different pieces of changes in their DNA, and that really tells you what kind of cancer it will be, and what kind of effects it will have. So that's at the most basic level, that's what a cancer is caused by. So kidney cancer, when we speak of kidney cancer, the other word we use is renal cell carcinoma. So renal is another word that means kidney, cells we just a cell, and carcinoma is a word that can mean a kind of cancer. So people will talk about renal cell carcinoma or RCC, and those tend to be words that are interchangeable with kidney cancer. So RCC or kidney cancer is increasing in frequency. A lot of other cancers are static or declining. So lung cancer, thankfully, is declining in men, but it's increasing in women because of smoking. Bowel cancer is a little bit better controlled these days with screening. Kidney cancer is still sort of going up and up and up. And the reason it's probably doing that is because some of the risk factors for developing a kidney cancer, the common types, are unfortunately pretty common in our community. Smoking, being overweight, having high blood pressure, things like that. The other thing, and I'll allude to that in a moment, is our detection of those cancers as well is increasing. But overall, it's still one of the it's still not a rare cancer, but it's uncommon compared to some of the common cancers like breast cancer, prostate cancer, bowel cancer, lung cancer. But it's in the top 10, so it's still an important cancer that we need to talk about. As Andrew described, sometimes these kinds of cancers can be inherited, they can be hereditary, and the von Hippel-Lindau syndrome is the most common variant of those. But that's probably only at most 5% of kidney cancer is hereditary, so most of it just is sheer bad luck, it just comes out of the blue. So what are the symptoms and the signs that you might find with a kidney cancer? Well, most of them, and this is probably the reason why we're seeing this apparent increase in kidney cancer, is that probably it's because we live in a rich country and we get scans for other things. We might have some indigestion, we might have some tummy pain, we might have a sore back, and we get another kind of X-ray or a CT scan or an ultrasound for another reason, and then we just happen to stumble across the fact that there's a lump in the kidney. So what I've tried to represent in the pie chart here is that mostly we find that the cancers, when we find it either in the kidney or just nearby the kidney, and thankfully only a smaller proportion of people was where the cancer is already spread when we discover it. Now, if you actually start to develop symptoms of the cancer, it can be things like finding blood in the urine, having pain in the flank, or sometimes having a lump in the stomach that your doctor can feel. And if the cancer has unfortunately spread when we first find it, then the symptoms depend on where it is spread to. If it's pain in the bones, sometimes it spreads to the bones, or if it's loss of appetite, sometimes the liver, or breathing problems, sometimes the lungs. So how do we make the diagnosis of kidney cancer? So normally we need to, it all comes down really to a biopsy, but sometimes we can find the cancer cells in the urine. As I said to you, an ultrasound or a CAT scan can often find it by those means. But in the end, what we really want to do is get a biopsy so we know what we're dealing with. And there's not really any specific blood test to tell you. There are a few cancers where we can do a blood test to tell you that this is the kind of cancer you have, but kidney cancer is not one of them. So this is a slice of a CAT scan, and this is the spine at the back. This is the person lying down on their back. This is their spine. That's their liver over there, and that's their right kidney and their left kidney. And here's a image of a patient who's got a kidney cancer on their right kidney. So there's the nice clean outline of the kidney here, and you can see that there's this irregular lump in that person's kidney there. So that's the kind of thing that we would see on the scans. So to get a biopsy, the X-ray doctors do this for us now, and they can do that with an ultrasound or a CT scan, and they can line up and then pop a needle and do a biopsy. It's extremely safe. The chance of getting a complication from the biopsy is very low, and the chance of the biopsy actually spreading the cancer is so rare that it's actually worth your while as a doctor writing it up and putting it into a medical journal. So we looked at this, for one of our research protocols, we actually looked at this and we could find 5 reports of that ever happening in the world ever. So it's an extraordinarily rare problems. The next question that people often ask is, can we detect kidney cancer earlier? So there's a lot of cancers now that we have screening programs for. So we have mammography for breast cancer. Ladies will have their pap smears for cervical cancer, to detect cervical cancer early. And everybody at the age of 50 should be having a colonoscopy to detect bowel cancer. But there's not really any good screening test as yet for kidney cancer. And there's no guidelines yet, but there's new technologies coming, and as those new technologies come along, maybe this will change. Maybe there will be a screening test, and we can certainly hope so. So I'd like to just talk to treatments. So there are traditional treatments for many cancers, and in fact for kidney cancer. So as I say to patients when I meet them in the clinic, we have knife, fire and poison. So the knife is surgery, the fire is radiation, the poison is chemotherapy. And in kidney cancer, there's a couple of novel treatments that are particularly useful here, and those are radio frequency treatment. So that's the little Wi-Fi sign down there, and kung fu is the other one. So that's really still in clinical trials. It's very, very close. It's coming. Kung fu. I'll talk about kung fu soon.
Haifu?
No, kung fu.
Fighting.
Self-defense. Immunotherapy. So, what kind of treatment would be useful for people depends on where the cancer is, and I'd like to very broadly define it as local treatment or treatment for where the cancer is advanced or where the cancer has spread. So, local treatments. Oh, let me talk about what local and advanced mean. So, local means that the cancer is still inside the kidney. In this case, it's smaller inside the kidney or larger inside the kidney. And advanced is when the cancer is spread beyond the kidney and is spread to distant organs. And then in the middle, there's this third sort of group, which we call sort of locally advanced, where the cancer has started to spread. It's spread outside the kidney, but it's still quite kind of local to where the kidney is. So that might be the lymph nodes next to the kidney, or it might be the blood vessels coming out of the kidney. So local, distant, or advanced. Locally advanced, and the treatment that is best for people depends on where the cancer is, and it also depends on the size of the cancer as well. So again, because we detect so many of these cancers so early, we often find X-rays where there's this little tiny spot on people's kidney, and you go, what do we do? Do we actually do a biopsy? Is it too small? Will we miss it? And so it's often one of the things we'll do is observe people with cancer. We won't actually do any treatment. We won't do an operation. We'll just watch until the cancer is a certain size. And so some people will have a cancer that might be 2 centimetres or 3 centimetres in size, and the surgeons, who are the first people who often provide the treatments to people with kidney cancer, will often just sit and watch and wait and wait to see what happens before embarking on what can be sometimes a bigger operation. So if it's a bigger cancer, certainly often it'll prompt people to advise treatment earlier. But if it's a smaller cancer, one of the things we'll often do is watch and wait. So that's what I was just speaking to, active surveillance. And this is actually something that's really not necessarily pioneered, but certainly led in the world by the doctors here at Princess Margaret Hospital in the urology service, where they will actually do something called active surveillance, where they'll watch people very, very carefully. And if you've got a small cancer and it's slow growing and you're an older person, and particularly if you have any other medical problems, the safest thing to do would look to be to actually just watch and wait, doing CT scans every so often, and then operate if you start to get into trouble. Because the operation itself might cause more harm than actually carrying the cancer with you. So surgery for local is a very useful treatment for cancer, for kidney cancer, and it's particularly useful if the cancer is confined to the kidney, if it's locally advanced, and if the cancer is causing symptoms somewhere else. So sometimes if people get a cancer that spreads to their brain, we can cut it out of the brain, and that's really the best treatment to do that. Or sometimes there's a group of patients with kidney cancer and with other cancers where the cancer started in one place and then moves to somewhere more distant, say the lungs, but it's only in 1 or 2 spots. And if it's only in 1 or 2 spots and you watch that person for a short period of time and nothing else comes up, sometimes we do something a little bit heroic. We'll cut out the first cancer and then cut out the other separate cancers. It's only a very small subset of people, and it's hard to pick the right people. But that it's called a metastatectomy. So metastasis is another word for when the cancer is spread. And if you have a metastatectomy, then what we can actually try and do is actually have people in a situation where we've cut all the cancer out of their body and we're crossing our fingers and hope that it's gone then. It's a very small number of patients that that's suitable for, so that's something that the surgeons are always on the lookout for and always looking to advise people about. So let's talk a little bit more about surgery. If you've got a small cancer in one of the kidneys, they'll often do something, the surgeons will often do something called a partial nephrectomy, which is the fancy way of saying they'll take part of the kidney out. And the part of the kidney out is just got the cancer, and then sew the kidney back together. If you've got, however, a much bigger cancer in the kidney, or the cancers, which is patients who've got a stage 1 or stage 2 kidney cancer, sometimes the only option is to take out the whole kidney, and that's called a radical nephrectomy. So partial means taking out part, radical means taking out the whole kidney. If the cancer has started to spread and is locally advanced, then again it's a bigger operation, take out the whole kidney, a radical nephrectomy, and perhaps cut out the cancer that's in the lymph nodes, or perhaps it's in the blood vessels. And again, that's the right treatment for some patients. And how do we do that? Well, we do that the old-fashioned way with a big incision around the flank. Well, when I say we, I don't do it, I'm not a surgeon. But these days there are newer treatments, the keyhole surgery, the laparoscopic surgery, and even laparoscopic surgery using a robot. So the robot's not actually, a robot doing it by itself. The robot is actually, there's one surgeon standing on one side of the patient, then the machine on the other side, and then the second surgeon actually sits at the computer console and shoots aliens or something. No, actually controls the instruments, and it's I believe there are technological reasons for doing it, that it makes it possibly a little bit more controlled in terms of the operation. Now we get to the next treatment for when the cancer is local. This is a really fascinating one, and again it's not necessarily pioneered, but certainly world leaders are here at Toronto General, and that's to use radiofrequency or cryo-ablation. So this is again the X-ray doctors, the radiologists who do this for us. They'll put a needle into the cancer from the outside, and then either put in freezing something like liquid nitrogen, or in fact what we do here is the radiofrequency. They'll put a little probe, a radiofrequency transmitter, and turn it on, and it's like a little microwave, and the little microwave that will cook an area that's about 3 or 4 centimeters in diameter. So for a smaller cancer in an older person who would not benefit from surgery, we can actually pop the probe in and cook the cancer from the inside, and it can actually be without terribly much symptoms, without a lot of pain, and can really control the cancer very well. So it's in the right patient, it's a really nice treatment. So is there a treatment after surgery or after the radiofrequency ablation if your cancer was local? Well, what we tend to do is we tend to follow people up in the clinic. You're regularly seen by your surgeon. You might have CT scans or ultrasounds and blood tests. But there's the other idea of an insurance policy. So in lots of other cancers, we offer an insurance policy treatment. So we'll offer some chemotherapy after you've had your bowel cancer or your breast cancer or your lung cancer cut out. Now, those clinical trials in kidney cancer are still underway. So when you do this kind of clinical trial, you have to have one group of patients who takes the treatment, another group of patients who doesn't, and then watch them for 5 to 10 years. So those clinical trials are underway with a number of different drugs. We don't know the answer to that yet. So there's no insurance policy to buy today, but we're actively researching that question. Now, what if the cancer spreads? Well, locally advanced, as I said, means spread to the lymph nodes or the blood vessels near to the kidney, but metastatic is the word we use when the cancer is spread to distant organs. And this is a situation that's usually treatable, but it's usually not curable. There are certainly some exceptions, but it's usually, we'd have to say it's usually not a curable situation. Where does kidney cancer spread to? It's not as promiscuous as cancers like melanoma. The cancer I treat in the clinic is melanoma. But kidney cancer likes a number of different places around the body. It likes the lung, it likes the liver, it likes lymph nodes, it likes bone, sometimes it likes brain. So what do we do to treat cancer that's advanced, or kidney cancer that's advanced or metastatic or spread? Well, we can use radiation. And radiation is useful if the cancer is causing problems in a particular location. So if there's bleeding from the kidney cancer, if there's cancer in a bone, bone metastasis, and that's causing pain, we can give radiation. Or if there's compression on the spinal cord, or if there's cancer in the brain, we can offer radiation in all those situations, and it's very effective in controlling the cancer and relieving the symptoms. So then what do we do in terms of drugs? So this is what I do. I'm the poison doctor. I'm a medical oncologist. I convince people to voluntarily take poison. So this is where we can offer different kinds of treatment for kidney cancer patients when the cancer is in more than one place. And so I've broken these up into sort of 3 different groups of treatments that we use now. There are tablets that actually target something called angiogenesis, and I'll define that in a second. There are some drugs that target some of the pathways and some of the gears and mechanisms and cogs that make the cancer grow. And there's an old and a new class of these kung fu drugs, these immune treatments. So there's an old set of immune treatments that aren't used that much anymore, but there's a new family of drugs that are coming that are pretty bloody exciting. Yeah, they're pretty exciting. Let me put one thing to rest. So poison like chemotherapy in kidney cancer really doesn't work. So each of these, I do this for other presentations when I'm talking to scientists and doctors, but each of these circles, the size of the circle represents the number of patients, and the centre of the circle represents how effective it was in a group of patients. And each colour represents a different chemotherapy drug. And so this graph represents about 30 years of clinical trials with about 60 different chemotherapy drugs. And the bottom line is that it only helped about 1 in 20 patients over all of that time. So this is chemotherapy where it's a substance that basically throws a spanner in the gears, causes all sorts of trouble in all sorts of the mechanisms in the cancer cell. But doing something that's that powerful and that toxic still gives you a really, really crappy result. And so chemotherapy is very, very infrequently offered for people with kidney cancer these days. There's a few chemotherapy drugs that are pretty gentle that have some effect, so that are sometimes used, but mostly they don't play a big part. Now, what I'm going to speak to now is a little bit about the angiogenesis drugs. But in order to do that, I just want to very briefly impose on Dr. Sridley's field and just talk about this. There are different kinds of kidney cancer, and that's all I'd like to say. There are different kinds, and the different kinds of kidney cancer then imply that there are different drug treatments that might be beneficial. So I'll leave the pathology to that. That's all I just wanted to say. So what I would like to talk about is the angiogenesis inhibitors. So angio means blood vessel, and genesis means growth. So blood vessel growth is angiogenesis, the growth of blood vessels. And every time a cancer has to grow, it has to establish its own blood supply. It has to lay down the pipes, lay down the plumbing. And so to get that blood supply into the cancer, to help it grow. And so one of the ways that people have thought to actually try and treat cancer is to cut off the blood supply. And so there are a number of different drugs that have been tried to actually try and do that. And kidney cancer has lots of blood vessels. So this is a slice of kidney cancer, and the brown tubes, so you can see the little tubes around the clear cells. The brown tubes are actually blood vessels. So it's a cancer that's got lots and lots and lots of blood vessels. So it seems like a really good idea to try and attack the cancer this way. So this is just another representation of that. And so the cancer is trying to get the blood vessel to form a blood supply. And so our angiogenesis inhibitors actually try and target that process. And so the other words that you might hear are things like targeted therapies, VEGF inhibitors, or tyrosine kinase inhibitors. Those are all the words, those are all the fancy words to describe this group of drugs that block blood vessels. And so there are a couple of different ways of doing that. The first way that doesn't tend to be used much anymore is a drug that tries to suck up all of these signals that the cancer gives to the blood vessels to try and say, lay down the pipes, give me the plumbing. And that's a drug called bevacizumab or Avastin, and that has been tried in kidney cancer, but is not that commonly used now. But there's a collection of other drugs from a number of different drug companies that actually work at the level of the blood vessel here itself, at the point where the signal, this message to the blood vessel is being sent, and to try and stop that from growing. And there's a selection of drugs like sunitinib, sorafenib, pazopanib, and a whole group of other ones that are coming as well. And they actually block this receptor and other ones, VEGF receptor. And so it's the place where the message is received is where those drugs block the signal and stop the blood vessels from growing. So these VEGF inhibitors, these angiogenesis inhibitors, they can shrink the cancer in some patients. And sometimes they don't necessarily shrink the cancer all that much. So one of the ways that we used to think about treating cancer was we've got to shrink it as much as possible. And it's the size of the cancer on the CAT scan that's the most important. That's not probably that true, because some patients get a really, really good benefit and the size of the cancer doesn't change all that much. So this is a person before treatment and after treatment, and the size of the big size of the cancer, it really hasn't changed all that much. But what you can see is that the inside of the cancer here has gone all rotten. It's what they call necrosis, which means that the inside of it's dead, it's got a rotten core. And so the cancer is causing a lot of symptoms to this patient because it's more dead on the inside, because the blood supply is being cut off. It hasn't shrunk down that much, but that's not to say that it's not actually still helping that patient quite a lot. So the effectiveness of these drugs, they tend to vary, and which drug is offered depends, as Deb said, on access and funding and what's available and what's around. And some are more potent than the others, but if you've got one that's less potent, you can increase the dose. They have slightly different side effects. Sometimes one is more effective than another in different patients, and it's hard to predict who will actually benefit. And there's a lot of work going on to try and figure out blood tests or tests on the cancer itself to figure out whether one treatment will help one patient or another. As a very rough rule of thumb, and so this is sort of statistics for everybody and doesn't necessarily speak to any one individual person, but for a rough rule of thumb, these drugs don't help about a quarter of patients up front. So there's a quarter of patients who don't derive a benefit from it, which is very disappointing, and it's a group of patients we need to work harder for. But a half of people will get what we call stable disease. The cancer doesn't necessarily shrink, but it stops growing and people often feel better. And roughly a quarter of patients will get what was called a partial response, which means shrinkage of the cancer and certainly some benefits as well. And if the treatment is effective, the duration of that benefit sort of tends to average somewhere between 9 to 12 months. Everything is really dependent on the individual. So statistics are nice for big groups when you're looking at pieces of paper, but they're sort of a bit meaningless for individual patients. There's no such thing as a free lunch, and so there are some side effects with these tablets. Fatigue is something that can affect people. It's probably fatigue and changes in your blood tests, which worry the doctors but don't necessarily actually mean that much for you. Those are the two more common ones. Sometimes people suffer some diarrhea, sometimes some other tummy upsets, some skin rash, some redness and soreness in the hands and feet, which is where hand creams can be very, very helpful, and other problems as well. But these are things that can often be managed and helped, and often they don't stop you from actually taking these tablets. So that's all I wanted to say about those. I have one slide about this other class of drugs, and I just put it up there to say mTOR. So with the chemotherapy, we threw a spanner into all of the gears. Now what we're doing with this class of drugs, there's two of them, they actually just block one of these little pathways. These are all the cancer pathways that drive a cancer, and we're just blocking one of them with these drugs. And they're called temsirolimus and everolimus. And they have found a role in patients where the kidney cancer is growing particularly fast to start with, or if you've had treatment with one of the angiogenesis inhibitors, one of the VEGF inhibitors, if the cancer starts to grow again after that, sometimes that we can use this as a second line of treatment. And that's all I want to say about that. They're there. The immunotherapy I wanted to speak to, there's past and sometimes present immunotherapy, which is a drug called interleukin-2, which is a hormone that stimulates the immune system. It's very toxic. It's given only in intensive care units. It's probably not, I don't think that there are many people using it in Canada. Some people using it in the States. And if in selected people, it can actually give sometimes dramatic results. Sometimes it doesn't work at all, just makes you very, very sick. Sometimes it gives very dramatic results, and there's even potentially people who've been cured by it. But it's expensive, it's toxic, and it's been proven very, very hard to test in clinical trials because of that toxicity. However, in the future, there are other drugs that also excite and aggravate the immune system, and they're targeting these two molecules called PD-1 and PD-L1. They're basically an antibody treatment that changes the balance of the immune system between the cancer and the immune system. And they're very much still in clinical trials. I think only last week they got names. They just had codes up until last week. But they've got names now. There's 3 different drugs. They're benefiting in the first set of clinical trials about a quarter of patients. The side effects are other things you might expect with the immune system, but the benefits of these ones have proven to be very exciting in clinical trials. So these are drugs you won't have heard of yet because they've only just got names, but there'll be ones that will be very, very interesting coming into the future. So what I wanted to just summarise here, this is sort of treatment options that we might have at the moment. And the only reason I wanted to put this up is to say that, you know, we previously, up until a few years ago, just had chemotherapy and it didn't work very well. But now we have a number of different drugs that might be right for some people in different situations. And we not only have drugs that are suitable for different people, but we've got ones we can use first line, second line, third line. So if a drug works and then stops working, then there's sometimes an option to use a second drug. So it's really nice to be able to offer different treatments to people in different situations and to have more than one arrow in your quiver. Last thing I want to say about complementary and alternative treatments, I want to make a really clear distinction there that complementary treatments can often be very, very good. That wellness is not merely the absence of illness. Okay, and so there's a lot of things that can improve your wellness, like having good exercise, having a healthy diet, yoga, meditation, acupuncture. A lot of those things can be very, very good for you as a person. But I want to contrast that to alternative treatments. And an alternative treatment is something that, whereas a treatment that claims to attack the cancer. And these can be very toxic. And they could be things like something called vitamin vitamin B17, which is also called laetrile, which is also called amygdalin, which is in fact apricot kernels. And in fact, the active ingredient of that is cyanide. And I have unfortunately seen, not patients with kidney cancer, but I have seen patients who took that and died. So the other thing is even if they don't cause terrible side effects, they can interact with other medications. So if you're considering an alternative therapy, please tell your doctor, your nurse, your pharmacist, please tell them we won't be angry, we won't laugh at you, but we just really need to know because they can influence things. And if you've been recommended something by a well-intentioned friend or loved one, that website, Quackwatch, is a very, very effective website for telling you about whether or not a treatment is really proven or is really sort of an alternative. So to take home, kidney cancer is increasing, but probably because we're finding lots of them earlier because of scans. Sometimes blood in the urine can be a presenting sign, or some of these other problems, but most often we just find them incidentally. The best treatment remains surgery. If we can get all of it and cut it out, that's very much the best treatment if we can remove it. Most cancers are not inherited. About 3 to 5% are, but most are not, and it was really just bad luck. When you're trying to put a treatment plan together, you need to sort of know a lot of the details about where the cancer is, what kind of cancer it is, what aggressiveness it is, and Dr. Schwigger will speak a lot more about understanding your pathology report to understand that. And while many of the cancers are cured by surgery, sometimes it can spread, but there are treatments that we can help in those kinds of situations. And you know, there's nothing like being an advocate for your own health. We really, you know, we really love it when people, you know, we do. We really love it when people take ownership for what's going on for them. Can I have a copy of my scans? Absolutely. Can I have a copy of your letter? Absolutely. No, can I see my blood test? Not a problem. Be an advocate for yourself. Look out for yourself, and by getting ownership of that, you'll have I think a much better path to wellness. So I think that was it. So I haven't spoken about any of my research at all. I'd just like to thank you again for your support. It's greatly appreciated, and thank you for your time.